those of you that are live streaming in. I want to make sure my voice is adequate enough for everybody can hear me. So for those of you that are live streaming in, if you can just kind of chat to Daniel, let him know that my voice is okay, or you can barely hear me, or I need to speak up. We can always make those little corrections. So the reason why we're here today, this is our formal train-up session into a revised dose of epinephrine that's going to affect on the 15th of November. The point behind this was not just this Paramedic 2 trial that came out. I mean, I think we've known for some time that epinephrine does not have a significant impact on neurologic recovery. The Paramedic 2 trial basically helped us confirm that it actually is associated with worse neurologic recovery in people that do survive epinephrine, or do survive cardiac arrest rather. So just a little history about epinephrine. They've been giving it we've been giving that standard ACLS protocol since the 1960s, and those studies were initially done on dogs. I don't know if there were any human trials that were done on epinephrine back then. They were all done on animals. And that's just kind of been our mantra, 1 milligram of epinephrine every 3 to 5 minutes. But what we've come to realize now are two things. Number one, a study that was released last year comparing late epi versus early epi. The patients who were given epinephrine early did worse than the patients who were given epinephrine later in cardiac arrest. And when I say late, I define late, or they define late, as after the second shock in VFib pulseless VTAC. So there was that study that came out last year, and of course the Paramedic 2 trial came out within the last 6 months, and showed that of the patients that do survive hospital discharge, more people that were given epinephrine had bad neurologic outcomes versus those that were given a placebo. And in the study, all they used was simply normal saline. This is the largest random controlled trial to date in the use of epinephrine pre-hospital, and it was done out of the UK. So we're going to go through some slides here just to kind of get us up to speed on why we're doing this. I can tell you that myself, Drs. Abraham and Manifold, Lieutenant Maldonado, Mr. Moya, we sat down probably a month and a half, 2 months ago or so now, and just basically had a discussion and what we could do to see if we can improve those statistics a little bit. I will point out to everybody that this is an experiment, right? I mean, this is kind of uncharted territory. What we do know is we think we're giving epinephrine too early, and we think we're giving too much of it over a relatively short period of time. And we hypothesize that is a factor that may be leading to worse neurologic recovery. I think there are a lot of factors there. When you look in the actual Paramedic 2 trial, for example, from the time of dispatch to the time that epinephrine was given was a little over 20 minutes. So you have to factor that in. So you can't read a study and say, oh, well, the end result said this. You have to know how to read research, number one, and know how to extrapolate those numbers and see exactly what it is they're saying. That being said, we still believe, OMD believes, and we tend to agree with them, that we're giving too much epinephrine. We're giving it too early, as opposed to giving 1,000 micrograms every 3 to 5 minutes, running a lower dose infusion over the duration of that cardiac arrest may be more beneficial to the patients. So Chief Torres, you can go ahead and just slip over to the slides right now. So let's take a look at this first slide right here. So as I said, epinephrine's been recommended in the ACLS guidelines since the 1960s, and we've consistently and methodically and religiously given it since then. Evidence does support that administration is less than ideal, and what I mean by that is in the dose and the timing interval in which we're currently giving it. We've known for a while, and the Paramedic 2 trial did confirm that we do get ROSC back more often when we give epinephrine. Now, mind you, this study was done based on a standard dose of 1 milligram every 3 to 5 minutes, and that was really not a surprise. We've known for several years, for actually probably longer than that we get ROSC back more often when we give epinephrine versus when we don't give epinephrine. So that was really not a surprise. But on the back end, the 30-day survival and beyond, what the patient's neurologic status is, that's what the Paramedic 2 trial kind of helped confirm for us, that there were more people who survived, more people that were given epinephrine had bad neurologic recoveries. And they define that as a modified Rankin scale of greater than 3, which is basically just a measure of neurologic recovery. So these are some studies going back all the way to 2002 And there have been a lot of studies that have been done on epinephrine, some large, some small. The Paramedic 2 trial was the largest one to date. You kind of see a consistent pattern there: increased ROSC, increased ROSC, increased ROSC, no difference in survival, no difference in survival. And then finally culminating in the Paramedic 2 trial, where it actually showed that the neurologic recovery is worse in people that got epinephrine. And again, that's in a standard dose of 1 milligram every 3 to 5 minutes. So these are some of the theoretical beneficial effects of epinephrine during cardiac arrest. So when you think about it, we're generating forward flow with our chest compressions, and if we give a vasoactive drug like epinephrine and create some quote unquote therapeutic resistance to our forward flow. Because remember, the coronary arteries fill during diastole, they don't fill during systole. So if we created a little bit of a vasopressor effect, then theoretically that should cause more blood to backwash down the aorta during diastole and fill the coronaries. And that was the scientific impetus behind giving epinephrine, kind of just like a balloon pump. When somebody puts in a balloon pump, they inflate that balloon during diastole, and that forces more blood back down to the aorta to fill the coronaries. So it's kind of a crude example, but that's essentially the science behind why we're giving epinephrine for people who had no pulse. And that would probably explain why we get ROSC back more often. I think we are getting enhanced coronary perfusion. The problem is that you have a lot of cerebral vasoconstriction. And if we give a patient, say we work on a rest over 20, 25, 30 minutes, and we give them 1 milligram, say every 5 minutes, then that's a lot of epinephrine. We get a pulse back on these people, which with enough epinephrine, you can resuscitate a dead elephant. But they have a sustained vasoconstriction, specifically in the microcirculatory flow of the brain. And again, I think that's one of the more popular theories as to why the neurologic outcomes are just not as good when we're giving epinephrine in that standard dose. So you can see all these physiologic effects here that are alpha specific, and your beta specific effects. Anytime you give a catecholamine or a catecholamine-like drug, you're going to get an increase in oxygen demand, increase in oxygen consumption. Obviously, clearly an issue if you're dealing with somebody who has a pulse. Say, for example, a patient's having an MI. However, that's still not a good effect to have in a patient who's in cardiac arrest. It can propagate dysrhythmias, especially in a very, very low flow state. But again, in patients who are spontaneously perfusing as well. And then, like I mentioned earlier, a decrease in microcirculatory flow, which seems to be kind of extended over a period of time, at least until that epinephrine is metabolized out of the body. The question is, how long does it take all of that epinephrine? And number two, how much did we give during that cardiac arrest? So, I mean, if we gave 10, 15 milligrams of epinephrine over a resuscitation, then you can imagine the sustained vasoconstriction that's going on, specifically in that microcirculatory flow. So the bottom line is that we are getting ROSC back more often, and we knew that. That wasn't a surprise. However, on the back end, more people that get epinephrine are not doing well. So put it bluntly, we're essentially making more vegetables with the current dose of epinephrine that we're giving. So we feel that we have to do something to at least see what kind of outcome we can achieve with less epinephrine, and again, kind of delaying it a little bit. So here's a breakdown of the Paramedic 2 trial, and this is free open access medical education, so you can pull this study down from the internet. It was published, the Brits did it, we won't hold that against them. But nonetheless, they did a great job putting this together. 8,000 patients, and they were split pretty evenly between those that got epinephrine and those that got placebo or normal saline. You can see return to spontaneous circulation was robust compared with placebo, 37, basically 36% versus basically 12% with placebo. And the measured rate of survival at 30 days was a little bit better in the epinephrine group, in the big scheme of things is not statistically significant, those that are alive at 30 days. This was really the significant factor here, was that 31%, so of those patients that do survive, so I'm going to go back to this slide here, of the 3.2% that do survive, 31% of those have a bad neurologic outcome, versus basically 18% with those who had a placebo. So again, in the big scheme of things, we're not talking about a large number of people. You're talking about 39 patients versus 16 patients, but the end result is still pretty compelling when you look at the neurologic outcome.
Did age or anything else?
So the question is, did age play a factor? So when they split the groups, they split them pretty evenly in terms of, comorbidities and age. I mean, they didn't put the patients that were most likely going to die in one arm and put patients who were least likely to die in the other arm. So that's one of the first things you look at in a study like TET. If they put all the people that were down for 20 minutes before anybody got to them, and they had hypertension and diabetes, well, you're giving epinephrine to people who are probably going to die anyway. So that could effectively skew your study. If they actually broke down, it's actually a pretty even split between age and things like that. One thing I do want to point out again is that the average time from dispatch to epinephrine on board was 20 minutes. So, and again, keeping in mind that those groups were split evenly, can we truly say that it's epinephrine exclusively that's leading to worse neurologic outcomes? And I think the answer is no. I don't think we can say that. I think it's multifactorial. You have patients that are in asystole, you have patients that were witnessed VFib, you have patients that were unwitnessed. But when you break everything down and you just throw it all in a bucket and spit it out, this is what we came up with, or this is what they came up with. So higher rate of 30-day survival, small, but a little bit higher, but no significant difference in favorable neurologic outcomes. And again, the group that got epinephrine actually did worse in that particular setting. So this is the take-home point that we got from this. I've probably read the Paramedic 2 trial, I don't know, 7 or 8 times, because there are some things that you have to kind of sort through there when you look at, the way they split the patient group, the patient populations up, and when you look at absolute survivors versus, those who could have benefited from it most. I think we'd all agree that, we're having a discussion about epinephrine today, but I don't want that to detract away from 2 things: high quality CPR and early defibrillation. So it doesn't make any difference when you give epinephrine, late, early, if your CPR sucks and you're not addressing ventricular fibrillation in a timely fashion, then we can forget about this epinephrine discussion. So we're talking about one therapy in one particular population. Basically, cardiac arrest is simply profound hypotension with 1,000 different causes, right? So we're trying to address this one little element of it. There are other things we will be talking about in the future. We already know, for example, that effective 1 November, and this has been on our protocols for the last several years, but OMB wants us to get that head elevated, head and torso 20 to 30 degrees during cardiac arrest. We do have a plan in our system to make that happen. And we have some gentlemen that are working on a very ingenious device that are going to facilitate that. So I want to make sure that we understand that epinephrine is just one little piece of the puzzle right here. Keep in mind that there were a subset of patients in these cardiac arrests that received no epinephrine at all. So are we quote unquote off the reservation when we're doing this? I think that we're not doing what the majority of the country is doing, but I think we're doing something that's really, really positive, and that's we're looking at our outcomes and we're looking at the data. And we're asking ourselves, is there something that we could do that could facilitate that, or are we just going to stay in line with 1 milligram until if and when the American Heart Association finally says, hey, we should probably consider changing your dose, which could theoretically be another 4, 5, or 6 years. I think the time for us to act is right now, at least so we can start getting some use. So what does all this mean? Epi 1 milligram every 3 to 5 minutes may be more harmful than beneficial. When I say harmful, I think if you ask the average American what they consider to be a good outcome, it's not going to be a persistent vegetative state. And that's what they did in this study, was they asked people, what would you want to return back to if you were in cardiac arrest? And obviously, overwhelmingly, people said my former self. So when we look at ROS, we can't just look at that. I mean, yes, it takes ROS to get survival to hospital discharge, but ROS is just that, return to spontaneous circulation. The end game is what we should be looking at. How many people are going home alive? How many people are going home alive with a good neurologic outcome versus how many people we get pulse back? If you'll recall back 10, 15 years ago, that was the standard that we in EMS were measured against. How many people we got a pulse back on? We got you to the hospital with a pulse, then we gave ourselves a pat on the back. You got to the hospital with a pulse, did a good job. But we're not held to that standard anymore. We're held to the standards that everybody else is. How many more people are surviving hospital discharge neurologically intact? And we just don't want to continue to hammer home a drug that evidence is telling us is probably too much and probably too early. Epinephrine should be administered on a case-by-case basis. For example, patients with traumatic cardiac arrest, are they going to benefit from a vasoactive drug? Are they going to benefit from a vasopressor? The answer is no. I mean, number one, epinephrine is probably not going to work in that subset of patients. Number two, The reason why they're in arrest is probably because they bled to death, or they have some other catastrophic thing going on in which your standard ACLS therapy is just not going to work. Lower doses of epinephrine may be more beneficial, and that's our theory, and that's what formulated this whole discussion of us going to a lower dose of epinephrine and giving it more as a slow infusion to maintain some degree of vasoconstriction, to continue to enhance coronary blood flow, but not just sucker punch them with a milligram every 3 to 5 minutes. These are our dosing regimens for systems under Manifold and Abraham that do not have an IV infusion pump. The dose for your ventricular fibrillation and pulseless V-tach is going to be cut in half at 0.5 milligrams. And we went from every 3 to 5 minutes to just every 5 minutes. So your epinephrine from here on out, if it's going to be given in a bolus form, it's going to be given every 5 minutes. So that's for VFib, pulseless V-tach. For non-shockable rhythms, we opted to stay with the current recommended dosing regimen of 1 milligram every 5 minutes. And again, the only edit we really made there was go from every 3 to 5 minutes to every 5 minutes. So that's if you do not have an infusion pump, or if you have an infusion pump and that infusion pump fails and the situation cannot be immediately remedied. If you have some kind of infusion pump failure, then these are the dosing regimens that you'll revert to in that particular scenario there. Keep in mind that for your shockable rhythms, epinephrine, this is something the American Heart Association has said for years. They have not recommended epinephrine therapy commence until after the second shock. But based upon prior studies, most of them really small, that said, hey, epinephrine, if it's going to work, it's going to work early. Well, the study last year that was published, which was a much larger study, said, no, that's not the case. If epinephrine is going to work, it's probably going to work later. So any epinephrine in VFib, pulses, V-tach, whether it's an infusion or in a bolus form, is going to be given after the second shock. So what does that mean for those of us that have infusion pumps? That means we're not going to be, we don't have to work fast. We have basically 4 or 5 minutes to get our infusion mixed. So, and then Dr. Abraham has brought up a good point in several cases. If we know we're going to a cardiac arrest, then pre-mix your epinephrine while you're en route. Just get the bag primed and everything ready. So all you have to do is just put it on pump when you get there. So that's something that for everybody, consider at a systems level. But our epinephrine is not going to be beginning until after the second shot. For those of us that actually do have an infusion pump, no more bolus dose epinephrine for VFib, pulses, V-tach. After the second shot, if the patient is still refractory, then we're going to start an infusion at 50 micrograms per minute. So for those of you that have an infusion pump, we're going to go through a little demonstration here and show you a couple different pumps. But I realize that some of us have pumps and others, so this is going to be a very department-specific thing that you guys get together and practice with your own infusion pump, pre-program them, set up whatever system you currently have. But 50 micrograms per minute starting after the second shot for your VFib, pulses, V-tach. In your non-shockable rhythms, Dr. Manifold still wants he still wants a milligram loading dose of 1 milligram bolus, and that's going to be whether you're using a pump or not. And that would theoretically be as soon as possible, because now we're talking about a different subset of patients. We're talking about those who are non-shockable. We're talking about those who are likely outside that window of being able to get early ROSC back on them. Don't get me wrong, people do survive asystole, they survive it all the time. But in that subset of patients, we probably would want to get epinephrine on board a little bit earlier. Once we get that 1 milligram loading dose, then shortly there, or actually immediately thereafter, we're going to start our infusion at 100 micrograms per minute. And we're just going to let that run throughout the entire duration of our cardiac arrest. And it's very, it's a very specific mandate of Office of Medical Directors for running epinephrine infusions must be on an infusion pump, as opposed to just, we're beyond the days of counting the number of drips, and even dilaflows and things are not going to provide you the most accurate. I'm sure we could probably come up with a million ingenious ways to make it work, but if you have a pump, these are the dosing regimens that you're going to be using. So that applies to us at Bulverde Spring Branch, applies to District 7, and any system out there that actually has an infusion pump. That's what we're going to be going with.
Is there some reason why we couldn't keep one pre-mixed bag? I mean, once you dilute it, does it lose?
Well, so once you spike a bag and put anything in it, you have to use it within 24 hours. So that's the problem with that. So it would be cost prohibitive. And that is a good question. But I think that if I agree with Dr. Abraham, if we know we're going for a CPR in progress, then getting our epinephrine mixed while we're en route may be a viable option. The only downside of that is now you're dealing with a needle in the back of a moving ambulance. So when we talk about the mixing direction that we came up with, that's the first thing that we're keeping in the front of our mind is what can we do in making this infusion to minimize the risk of a needle stick, because it's all about taking care of ourselves first. So we threw around the idea of putting 1 to 1,000 epinephrine in 250 cc's, which is common practice when they're mixing drugs in the hospital and in a lot of pre-hospital settings. But I've also seen literature on using 1 to 10,000. At the end of the day, 1 milligram is 1 milligram, right? So if you had 4 ampules, for example, or 4 ampules you have to crack open, that's 4 risks of you getting cut or stuck. And then even though you're using a blunt tip filter needle, I've cut myself and stuck myself with blunt tip needles. And maybe it's just because I'm an idiot, but I've actually stuck myself with a blunt tip needle before. So the less needle handling we can do, the safer it is going to be for us. And that is the bottom line at the end of the day. We have to make sure that this is safe for us.
This is probably also a good place to point out, we talked about getting combined premix epi, which you can get from drug suppliers, but the cost was exorbitant. I mean, like hundreds of dollars more than.
With a 90-day shelf life, if I remember correctly, I think that's what I saw. So basically a 3-month shelf life.
Yeah, see, I also had a theory of the reason you stuck yourself with them was that it was made
Yeah. Yeah.
What do they do to pre-mix?
They just
Sit right there.
I think there's a little bit of preservative added, and it mostly it's done in sterile. So the part of the risk is that for us in the pre-hospital setting, if we were to mix it ourselves, we are introducing some bacteria just because we're not in a airtight, completely sealed, sterile environment. So especially bouncing around the back ambulance, you're going to be adding some bacteria to that. If you use it quickly, not a problem. If you let it sit there, the bacteria can start to grow.
Bottom line though is it's expensive. And I mean, I can speak for Wolverine Spring Branch. We're up to 24 cardiac arrests this year. So we don't work a lot of arrests. And I don't know if the cost benefit ratio would be. I think that we have a lot of epinephrine that's expiring off a lot of drugs. And then we look at the cost. But anyway, this was the solution that we came up with, and I want to point out that a lot of folks might not find this to be the easiest, the most desirable, but I can tell you that Dr. Manifold was insistent that we're all going to do this the same way. Because, and I do agree with him, this whole process we should expect to be scrutinized for. And I don't mean bashed, I mean scrutinized. There are going to be people that are going to be asking, why are you guys running epinephrine infusions of cardiac arrest to begin with? And when we're talking about something that is not standard medical practice in every system that you go to, I think we should expect those kinds of questions. And the answer would be very simple. We believe that we're giving too much epinephrine, and we believe that we're giving it too early. So are we going to stay at these dosing regimens forever? Who knows? I mean, we might find a robust increase in survival to hospital discharge, or we might find something that's worse. But the bottom line is we're still giving epinephrine during cardiac arrest. We're not going against that standard. We're just coming up with a revised dose for that. So our mixing instructions are 4 milligrams of 1 to 10,000 and 250 mLs. That's going to involve you withdrawing 40 mLs out of your bag of normal saline, and then just taking 4 Bristol jets of Epi 1 to 10 and putting them in there to come up with a total of 250 mLs. Now, I know that there are pumps that can be programmed a certain way where you just put the number of milligrams and the amount of volume and it calculates it for you. Some pumps can do that, other pumps may not be able to do that. So we want to come up with an even 16 micrograms per ml. And the only way we're going to be able to do that is if we have exactly 4 milligrams and exactly 250 mLs. Anything else, you're dealing with decimal points now. And if you don't have a pump that has the ability to auto-calculate your concentration, now you're going to have to remember something in decimal points. And as humans, we don't do very well in remembering things in decimal points. So we're all going to have a 16 mic per ml concentration. After we inject the 4 10 milliliter pre-filled syringes in, we're going to lightly mix the bag. Don't shake it around because it can kind of foam up. Just kind of lightly mix the bag, and then set it up and run it through your infusion pump. And again, this is very device specific. We carry the Sapphires that are made by Hospira. District 7 carries a different pump. Other systems may carry different pumps, but the bottom line is that 4 milligrams into 250 mLs total for 16 micrograms. per ml. And then from there, however you run it through your infusion pump, because some pumps require special tubing, that have little filters in them and little cartridges. Others may not. So, is any questions so far? Yes, Lou.
If you would go back to the last slide.
The last slide. All right.
So connect the IV catheter hub in the patient, no saline lock. My thought process on this was in a cardiac arrest, we're gonna have an IO. It's probably gonna be running fluids because I believe that's typically priority over epi administration. A lot of cardiac arrest is getting at least a liter in. And so in my head, I was like, well, I'm just gonna piggyback this into that.
So
that says I'm not going to do that. So
right. So
second IO?
we should be getting 2 routes of vascular access in cardiac arrest. I mean,
okay. Like 2 immediate.
I think that if we can get in an IV and an IO, that would be great.
Okay.
I think just for time's sake, it's quicker to just put an IO in the distal femur.
Yeah.
But I did a flow study on, mind you, this is N of 1. On a cadaver down there a couple of weeks ago, where I put an IO in the distal femur, flushed it with about 40 cc's of fluid, and ran the epi drip at 50 mics per minute.
Okay.
I did that for about 20 minutes, and then I cranked it up to 100 mics per minute and didn't get one alarm. So I know that was a concern for some people is will the pressure in the intramedullary cavity overcome the pressure of the pump? And I can tell you that on our pumps, at least on that one specimen, it did not.
Did you do it in humerus too?
What's that?
Did you do it in the humerus?
I did. I just did it in the distal femur because that's typically our go-to spot. So I'm thinking, I mean, this is a thinner bone. It's going to flow better anyway.
So I've been kind of starting doing 2 routes of access, but I'll do 1 distal, 1 humerus.
So we've, New Braunfels Fire Department has been doing this for a couple of weeks now with the epi drips. We've had 2 distal femurs and 1 humerus for cardiac arrest. We had a little bit of flow issues with one of the distal femurs, but on review, it looks like the IO may not have been properly placed. Other than that, we had no issues with flowing it from either route. My other thought, incidentally, this is completely a different topic. We used to emphasize a liter of fluid under cardiac arrest. What we're starting to find now is it depends on what's causing cardiac arrest. So if you have a patient who's in cardiac arrest because of something cardiac, so like a massive STEMI or something like that, and they're in cardiogenic shock, giving them additional fluid is actually one of the worst things.
Yeah, I agree with that.
So, if consider what you think is causing the patient's cardiac arrest before you go straight to the
I mean, immediately when we get there, I mean, we should be getting our whole PIP crew thing going, getting our BLS established, our BLS airway management, defibrillating the patient if they need to be shocked. We know that we're going to be giving epinephrine in some form. And whether we run it at 50 or 100 mics, that's the only unknown. So the mixing is not going to change. So, during that period of time where you're getting your CPR started, if you're doing mechanical CPR, then somebody would be mixing the epinephrine. But I mean, if you look at the way cardiac arrests are worked in hospitals, they don't just have one route of vascular access. And historically, many of us have had one route of vascular access because we push our drugs, we get fluid boluses and things like that. Well, now we're running a continuous infusion. And I think that line needs to be dedicated for that.
I've had concerns about that before. It's we're running cardiac arrest and giving, bicarb and calcium to the same line and stuff.
Oh, yeah.
Well, that's not clinically indicated.
Yeah. Well, I mean, as long as you flush the line,
yeah,
I think you're fine. If you're just like one right after the other, then you get a basic chalk is what you're making, calcium carbonate. But no, I think it needs to be a routine practice that we have 2 routes of vascular access.
Yeah.
One for our infusion, one for any bolus meds that we may need to give, amiodarone, for example, or calcium or things like that, or for fluid boluses. So whether you go an IO and an IV or 2 IOs, that's totally up to you. Okay. Yes.
We do have an online question at this time, and I guess for Dr. Abraham. Will the ERs be notified of our change? And what is my answer to them, my response to it?
So your answer, I'll answer the second one there first. Your answer anytime you roll in with a patient and you're doing something according to your protocols and it's not what the hospitals are used to, is to give them either my information or Dr. Manifold's information and remind the ER staff that you are a EMT or paramedic following your medical director's protocols. And if they have a problem with it, they need to be talking to the medical director, not to you. Okay, that's your first answer. The second answer is we've notified some of the ERs. There's been discussion at Stratf and stuff like that, so the word is starting to spread. I don't know that it's been terribly practical for us to send a mass notification out to every single ER in San Antonio that you can transport to. So you should expect that some of the, and even if we send a blanket notification out, you know that like 3 people in the ER are actually going to read the notification.
That would be a good day.
That would be a good day.
Yeah.
So don't expect that folks are going to know what's going on when you roll in. Okay, you're going to have to take a second and say, hey, we've got epinephrine drip going on. Here's the rate that it's been running at, which is the equivalent of, so for your 100 mics a minute, you can tell them it's the equivalent of 1 milligram of epi every 10 minutes. And what the hospital is probably going to do is, turn off your drip and start giving epi on their own rate. That's what we've seen of the few cardiac arrests that have actually made it to the hospital. The other thing to remember is it's a cardiac arrest, which means you should be working it in the field and getting ROSC in the field, and there should be very few circumstances where you're actually transporting these patients to the hospital in the first place. Okay. Your refractory VFib VTAC patients, the kind of patients who are going to go to ECMO at Methodist or something like that, might be your only, maybe your PE, maybe your, pregnant patient, that kind of stuff. But beyond that, the hospital should need to be seeing these patients.
I agree, we're talking about a very small subset of patients, but there are patients who may arrest en route.
Yeah.
So I mean,
Yeah, so those patients
obviously.
who may be. I think the biggest thing to emphasize, and this goes for all of our protocols, because we are such an advanced system, because we are, out ahead of even other EMS agencies, and definitely out ahead of where the emergency medicine and medical, like physician world is, you should expect that you're going to get weird looks and questions on a lot of stuff. Whether it be the antibiotics or the epidrips or the no backboards, a couple months ago, or any of that kind of stuff. And your answer is always that I'm following my protocols. Here's my medical director's.
And we're more advanced than
But remember that you're also supposed to be nice, so that I don't have to apologize for your behavior and defend your behavior at the same time.
No, I can tell you that this 50 mics per minute and VFib pulses VTAC was not entirely something we pulled out of our butt. Okay. And we actually did some research, and there, Dr. Razai, Sal Razai, he's with GCEP, and he runs a Rebel EM webcast and or podcast and website. And that's basically where we get 0.5 mics per kilo per minute. And we're just going to assume adults are 100 kilograms. So we're getting 50 mics per minute. Now, the 100 mics per minute for the asystole PEA, that is something that we did partially pull out. But we figured, well, that's a subset of patients that statistically are likely going to need more epinephrine anyway.
So I mean, that's just AHA ROS protocol anyway. It's like topping out.
So partly, and where we pulled that from is also that in your refractory VFib VTAC patients, we think that there's a catecholamine storm going on, which is what's causing their persistent excited state of their myocardium. It's the same reason that we do esmolol drips for those of us who have esmolol, because you're given a beta blocker in a cardiac arrest to calm down that catecholamine storm. So our thought process was, we're going to give even less epi to those patients in an effort to maybe get out of the refractory state.
I like your answer better than mine. No, this was not all pulled out of our butt. So there's actually some science behind it.
It's actually science.
But it'll be interesting to see. It'll be interesting to see once we get this going, what kind of results we see. And I mean, obviously, we're going to be in good contact with OMD and all the systems. Providing feedback, letting us know, which means we're going to have to do really, really good follow-up on our patients. And that's something that needs to be addressed, because, right now, I mean, I think for most of us, we work a cardiac arrest and we get a pulse back on them, we maintain a pulse, we take them to the hospital, they're admitted to the ER with a pulse, they go to the ICU with a pulse, they go to CT with a pulse, therapeutic, and all that stuff. And then I think the most of us are getting right now is, they went home and they're doing well. Well, we still want to look at 30-day survival if we can, because that's what this study showed, was that neuro outcomes were worse at 30 days. So I think we need to come up with a system of being able to follow these patients for a longer period of time. I don't know what the magic bullet is to that. I really don't. I wish I did. But I can tell you that, yes, if you go home, you survive hospital discharge, and you and you're driven back up here, or you drive back up to the fire station or the EMS station, and you walk in on your own accord and you say, hey, thank you very much. And oh, by the way, I remember every Christmas, Easter, and Thanksgiving, but I'm thinking you're probably going to do okay. But we still want to the best of our ability, see how these folks are doing at 30 days. That's really the only way that we can draw a parallel between the results of Paramedic 2 and what we're doing with this, is how these folks are at 30 days. Now, I can tell you that, I mean, if you have a CPC of 1 or 2 or a modified ranking of less than 3 when you're discharged from the hospital, unless something catastrophic happens within the next 25 or 26 days, then your neurologic outcome is probably going to be the same at 30 days. But that's just something for us to consider. We want to know how our patients are doing longer term, not just were they discharged from the hospital alive. How well alive are they? What kind of cerebral function do they have? So
I want to go back a second to the previous question and kind of jump on one of my favorite soapboxes, which is that you guys are clinicians, okay? You're not just technicians, you're not just following protocols. Chief Brown mentioned that we're better than everybody else, we're ahead of everybody else. We are, but you should take advantage of that to try and respectfully, politely educate some of the folks in the ER. You should understand why we're doing what we're doing. That's part of why we're having this lecture here today. So that when you explain to the nurse or the physician or whoever, here's what we did and here's why, some of those docs may start to say, oh, that's an interesting thought, and they'll start, doing a little bit of their own research. Maybe they'll reach out to us, maybe they'll, Google, whatever, and they may start changing their practice too. Okay. Which is part of what we're doing in EMS. Partly we are, trying to provide the best possible care to the patient. Partly we are effecting change throughout the whole healthcare system. And one of the ways that we do that is through the discussions that we have with those nurses and physicians when we're in here. So have a good understanding of why we're doing what we're doing, so you can at least have some of those preliminary discussions.
all right, awesome. Any questions so far? As far as the history, why we're doing this, any reservations, any reservations that folks have about doing this? So, I mean, it's a new concept. It's just a different dose of the same drug. So, I mean, we run infusions, a lot. So we're just running an infusion during cardiac arrest. Yes.
Question from the audience. It says, will the PD doses stay the same following AHA guidelines? As far as this is only for adults, is my understanding.
Correct. We've not addressed any pediatric dosing changes.
Part of the thought process behind that, before he says we pulled that out of that too, is that adults tend to go into arrest for cardiac reasons. Kids tend to go into arrest for very different reasons. Respiratory is the most common cause, and then other, congenital cardiac diseases and stuff like that. So epinephrine in adults, we think that bringing it down is going to help with the heart and the brain kind of thing. For kids, we think there's so much other stuff going on that, have a good focus on air management, have a good focus on ventilation, have a good focus on toxicology and stuff like that. And we're going to leave the epi where it is for right now. Kids are also a lot more resilient than adults, so they can probably handle some of those shifts a little bit better than adults can.
Good question. Good question. Any other questions? Yes.
So I know San Antonio changed their epi back early this year to like 0.5 milligram, right? So what's the difference in, that's basically what we're giving is 0.5 milligram every 5 minutes, right? So what's the difference in this, like the steady infusion versus just cutting the dose in half?
It's just that. It's a steady infusion versus this every 5 minutes, right?
So remember how in traumatic brain injury, in traumatic brain injury, one single episode of hypotension is harmful to that brain, right? What we're doing right now in cardiac arrest with our bolus dosing is we're giving the brain good perfusion and then we're dropping it, and we're giving it good perfusion and we're dropping it. And we're basically giving it that hypotension every couple of minutes. So a single episode is that with increases mortality rates in traumatic brain injury. Well, we're giving these patients 5, 6, 7 episodes of hypotension, alternating with 5 or 6 episodes of severe hypertension every time we push the epinephrine. Yeah. So by giving it at a steady rate, we're hoping to have more the effect of like when you start Levophed for a patient who's in septic shock or something like that, where you're giving a steady increase in their blood pressure rather than doing the roller coaster. Does that kind of make sense?
Mm-hmm. And they're capping their dose. They give a total of 2 milligrams in an asystole PE and a total of 1 milligram in BFib. So they've they've actually taken a little bit further, they're actually capping their dose that they give. We believe that if we can achieve a somewhat consistent level of vasoconstriction and not peak and valley that you may get with bolus dosing, like Dr. Abraham said, we think that may be better off for our patients' neurologic recovery in the long term. Especially when we get pulses back, because we've been running a slow, steady infusion, and now they get return of spontaneous circulation. Now their body has to do something with that 10, 12, 15 milligrams of epinephrine that we just gave. And it's just going to clamp down the vasculature in the brain. The microcirculatory flow is going to take a big hit. So, this is going to be an ongoing thing. We're going to have to watch. I know we watch outcomes in our systems, but we're going to have to look at them a lot more carefully now. And again, see if we can get information on our patients beyond just survival to hospital discharge. If we can see how these folks are doing at 30 days, then so much the better. I mean, it's not like we're working, 500-600 cardiac arrests per year. So we're talking a pretty small number of patients that we follow up. If we can't get follow up on them, then we can't. I mean, we just can't. I think that especially in an area where we work 15, 20, 30 cardiac arrests per year, I think at 30 days I would probably call the patient. Just do a follow up with the patient, call them at home, and see how they're doing. Because you're not going to get that information from the hospital. It's going to be very difficult. We get survival to hospital discharge, and most of the time we don't get a CPC because they're like, "What is that?" Like, you don't know what a CPC is? Well, I mean, if a patient comes back and talks to you, shakes your hand, and knows who everybody is, I'm thinking CPC of 1. So that may be an outlet for getting better patient follow up, is to call them 1 month later, call them at 30 days, and see how they're doing.
Another online question: what do we do with the epi drip after ROSC, especially in regards to the blood pressure?
Great question. So our protocols still call for Levophed as our first line pressor. However, in a cardiac arrest patient where you've just gotten ROSC, remember that those 5 minutes post ROSC are your most fragile moments of the entire arrest. They're actually even more critical than like the middle of the cardiac arrest. Because those 5 minutes are where you have a chance to stabilize everything and keep the patient from re-arresting. So for cardiac arrest, we're fine with leaving the epi drip running. Remember, you're probably going to need to back it way down, okay? Because even if you've got a V50 tach and you're running it at 50, 10 to 20 is probably a more reasonable rate as an actual pressor. So just keep a really close eye on the blood pressure post arrest. But for those first 5 to 10 minutes while you're getting your EKG and getting a blood pressure and making sure the airway is intact and all that kind of stuff, it's fine to leave the epi drip running as your pressor if needed. Just bring the dose weight. Keep an eye on it. You will probably need to bring the dose weight down. And actually, this is a good point to stick in. Also, probably should not actively be managing the airway in those first 5 minutes either, because that also is likely to cause the patient to re-arrest. Either because you're allowing some hypoxia during the intubation, or you're stimulating the vagal nerve, or even if the intubation goes completely smoothly, everybody's still focused on securing the airway, but you miss the fact that the patient just re-arrested, or just changed their pressure to 50 or something like that. So should not be intubating in those first 5 minutes either. Take that time to get your EKG, get your blood pressure, make sure the epidurip is where it needs to be. Start thinking about packaging and moving, but wait those 5 minutes before you start, either intubating the patient or moving the patient or whatever else you need to do. Eventually, we would like you to switch to a Levophed drip because that works better as a pressor for both cardiogenic and every other kind of shock. But for those first couple of minutes where you're still stabilizing everything, it's fine to leave the epi as you go.
And to dovetail onto that, so one thing that when we had our initial discussions that Dr. Manifold was talking about was intra-arrest blood pressure monitoring. So especially if you're doing mechanical CPR, if you get a blood pressure cuff on that patient, which we should be doing anyway. I mean, you walk into the cardiac arrest patient, we should probably not look at them as a cardiac arrest. We should look at pre-ROSC. That's the way we should look at it. Is they're not in cardiac arrest, they're in a pre-ROSC state. So if we get our blood pressure cuff on, get our pulse ox probe on them, and we cycle that blood pressure during the cardiac arrest, if you get 100 systolic blood pressure with your chest compressions, well, just ask yourself, would you be giving a patient a pressor if they had a systolic blood pressure of 100 if they had a pulse? And the answer is no, you wouldn't. So he kind of wants that to help guide our epinephrine therapy. And those are more conversations that we can have. If we're cycling the blood pressure during CPR and it's consistently giving us a systolic of 100 or better, then that may be an indication to start scaling back your epinephrine. We've not come up with how much are you going to scale it back, right? And those are for future discussions and for us to at least start getting the epinephrine infusion thing on board. But I think blood pressure monitoring during CPR is an important thing. And I get it, because I was the first one to ask him the question. So historically, a lot of times that thing just times out. The BP cuff times out, to which his reply was, then you're not generating enough perfusion. I'm like, okay, no, I'll give you that one. But if I can feel a femoral pulse during my chest compressions, then I think I'm generating some pretty good forward flow. But, you know, am I generating enough forward flow to actually make a blood pressure of 100? So we need to be doing two things in our cardiac arrest that may be a little different from what we've been doing before. Number two, routinely 2 routes of vascular access. And number 2, intra-arrest non-invasive blood pressure monitoring. So if we consistently see that our CPR is making a systolic pressure of 100 or greater, then we should consider titrating our epinephrine down. Would not advocate turning it off completely, because now we're basically starting from the ground back up again. But that may be one of those situations where we call medical control and ask them, say, hey, we've got this, you know, asystolic or VFib patient. Last 4 blood pressure readings we've got have been 102, 104, 106 or higher, and then let them help us make that decision on what we might want to consider titrating our dose back to. Okay.
You should have a very low threshold for going med control in these cases. We realize it's a new procedure. We realize there's a lot more thought and understanding of the pathology and stuff that goes into this. Feel free to call us. That's what we're here for. The other thing that Chief Brown kind of brings up is we may start seeing a little bit more conscious patients during a cardiac arrest. I don't know if any of you have ever had those cases where the patient's like blinking or looking at you or, you know, reaches. I mean, I've had that a couple of times now. And we should actually expect to see that a little bit more with these patients. A, that's an encouraging sign because that means that you're getting good brain perfusion. Freaky though, maybe. B, keep doing what you're doing because obviously it's working. Okay, that's not the moment that you're supposed to like all jump back and stop doing chest compressions. Okay, it's your good chest compressions and everything else that's allowing that patient to have that consciousness. Third, we may eventually need to look at some kind of sedation, probably with ketamine for those patients. That is something that you should call med control for. Please don't go starting ketamine in addition to the antidepressants. But be aware that that's something you should actually expect to see a little bit more of. Yeah.
So, any other questions?
I want to add something real quick to what you just said. Remember, guys, that this is just a small tool towards cardiac arrest survivability. One major tool that we especially want to bring up, especially when she said some of these patients will probably be blinking, might potentially be reacting to you. We are starting to do heads-up CPR. We should be doing heads-up CPR. So along with that, you should start seeing a lot more of what Dr. Abraham is referring to. A very small part of cardiac arrest survivability tools that will slowly be rolling out between now and the end of the year.
Yeah. For a long time, we've been focused on getting the heart back in cardiac arrest and kind of forgetting about the brain. It's time for us to start paying a little more attention to the brain. So as you're working in cardiac arrest and as you are doing your various interventions and thinking through what you're going to do, keep in mind that you're trying to take care of both things, right? You're trying to take care of the heart and you're trying to do everything possible to protect the brain and give the brain a good outcome as well.
Awesome.
Yeah.
I have a question for you regarding the 30 degrees thing.
Yeah.
All right. I just want to know if we have like ICP monitoring, any research based off of ICP monitoring in ICUs or ERs or anything like that.
Yes, we do. That's where we're getting the 30 degrees.
Okay.
Yeah.
What is the ICP typically in a cardiac arrest with mechanical CPR?
So, well, now you're asking for actual numbers. I don't remember actual numbers, but it gets better when you
Because
see the
I've looked at the maps. I've looked at the maps and stuff, and typical maps, I mean, are like 30s and mechanical CPR. So I was just like, that didn't correlate to me as a high ICP. But at the same time, I see a physical finding of the patient looks like crap when he is right down. So
Right, right.
well, you know, maybe it's one of those anomalies.
So you're getting, I think the 30 map is typically with just CPR. Once you add epi, your map starts to go up a little
Yeah.
bit. And then there is just the physiological state of all the venous blood is pooling in the brain.
And
When
that
they're
was one
like
of my
fine, then we
things,
stick
like,
them up.
okay, venous insurance sucks, like, when they're laying down.
Exactly,
flat, so,
exactly.
okay.
And that's probably our biggest difference because we can only do so much to improve the map coming from the heart by doing continuous compressions, no pause. Here's an emergency stop. You have to rebuild that pressure column over time. Epi, we're already doing everything we can to get the map sufficiently high.
Mhm.
Now we need to do what we can to decrease the other stuff going on in the brain so that what map there is can get up into the.
Yeah,
So we're lowering ICP, but we're increasing preload at the same time.
yeah,
There's more drainage of venous blood from the brain, more preload. So, I mean, the heads up thing is, it's not
Okay,
just
so-
about mitigating ICP, it's about improving preload as well.
Well, and when we roll out the new, or when you roll out the cardiac survivability tool, we'll address that. We'll have that research for you. We'll have the numbers to you. We'll definitely send it out to you guys. You got about 10 minutes if we want to start doing the.
Okay, yeah, so Lieutenant, why don't you bring your pump up here? All right, so this is a pump that we carry here. This is the Sapphire. So this is a very system-specific thing for us. But the general principle is the same. So you got your 250 ml bag. This is the one aspect here where we're actually using a needle. And I'll show you the blunt or the needleless system here in just a second. I'm just backing 40 cc's out of here. And actually, Andrew timed me here a couple of months ago,
I'm talking to you right now.
having never,
Of course.
keeping in mind, have not used a pump in a long time. It took me about 5 minutes. Okay,
That was with some issues.
yeah.
Can you turn on the rest of the lights?
So on our epinephrine here, and I realize that not all of them come with this system right here. Some of you may actually have to attach a needle to. But if you just take out your needleless port, you'd have to try to stick yourself. Okay, so that's one of the reasons why we decided to go with the 1 to 10,000. So then I'm just going to put my my 1 milligram in there. So. And we actually talked about using the same. We talked about using the same Bristojet cartridge to do that. Pay no attention to that mess. I have the needle outside the port there for a second. And I think what may happen is we're going to get some epinephrine that's going to come back up out of that. It's going to come back up out of that that Bristojet.
90 seconds. 90.
No, he's almost 2 minutes.
You guys remember, we actually don't want the epi to be on board like the very first thing in cardiac arrest, right?
Second shot, right?
It's the second
Yeah.
shot. Yep.
So I probably have the Hawthorne effect going. I'm going fast because I know I'm being timed.
It's just when you want to run sooner.
Okay.
But
That's what we're
the
doing, the
emphasis-
loading dose.
But you're getting, exactly, you're still giving a 1 milligram loading dose on your SSOPA,
We're
and
shooting.
you still need to have an emphasis on getting your compressions going, and you have to stick in an eye gel in there.
So with the ASIS with the, we're still doing the 4 milligrams of 250, or is it
So-
part of that,
It's
part
the-
of your 4 milligrams?
It's the
is
same
that first
mixture.
loading?
It's the same
So
mixture.
the ASSOPA gets a milligram up front. For both BTIP, BTAP, ASSOPA, everything, you're still doing 4 milligrams in
Okay.
there to create drip.
Or
Like
16.
you're then gonna set either 50 or 100 to
Okay.
create your 16, yeah.
Okay. Gotcha. All right.
I think you need to be in the pump and purge it.
Well, no, it's you just squeeze it back a little bit here.
Julie, go.
Okay. 3 minutes.
This is the other reason that we'd like you guys to practice on this over the next couple of weeks. New Braunfels, we've been able to bring our times down significantly just by, randomly throughout the day, somebody will throw the pump and equipment at, one of the medics, and he has to, see how fast he can get it set up. The other thing that we found helpful is we actually have a small bag that has the 250 bag, the 4 epi in it, and the pump sits in there too, and then that bag sits in the medic right next to the charger. So the pump is still charging, but everything is ready to go, so you can just unplug it, grab the bag and run in, and you're ready to set everything up right there.
So I'm priming it, I'm just purging a little bit. When I set it up the first time, I opened it up and squeezed the bag and it flushed within a very short period of time. But for some reason, that was just taking a little bit longer. All right, so now I've got fluid coming out, so I'll finish my prime. And then from here, all we're gonna do is start new infusion and then dose calculation. That's gonna be in micrograms per milliliter. We're gonna type in 16. And then, okay, it's not a weight-based infusion. We're going to run this in micrograms per minute. And we'll say we're going to start at 50, so our dose rate, 50 mics per minute. And then our volume to be infused is going to be 250. And that's going to give us an hour and 20 minutes out of that one pre-mixed bag. It's going to ask us to confirm. So we confirm, and then we start the infusion. So now it's running 50 mics per minute. Now remember with these devices right here, let's say we have a patient who's in VFib, pulseless VTAC, but then they deteriorate to asystole. So just hit that number right there, and then you can change real quickly to 100 micrograms. It'll ask you to confirm, and then you start running that in, and it changes to 100 micrograms per minute. Yes, Mark.
Real quick on those pumps for the PSD people. There is a software update that I'll be putting on the pumps in the next week or so. It's going to change a couple of things, nothing too crazy, but I will be doing some training and sending out a PowerPoint to everybody so that they'll know the slight differences.
Okay, cool. So how much time is that for those of you that were timing me? Now, don't look at your clock now.
No, I am.
Okay.
You're sitting at like 4.5 now.
Okay. So just be familiar with the pump that you're using. Like I said, I will do more experimenting with this on the cadavers. Probably put some IOs in the humerus. I may even just throw one in the tibia just for its and grins. But I can tell you that in the one cadaver that I ran it in, the pump pressure was able to overcome the intramedullary pressure, and it didn't kick off any kind of alarm. So if we're getting an alarm, it's often either for air bubbles or there's some kind of obstruction or something. So I would check to make sure, just like with anything, make sure your IO is patent. But nonetheless, we need to be getting at least 2 rods of vascular access. Okay. LT, you have anything to show on your pump there?
Yeah. So for those who are familiar with the Bodyguard 120 pump, the process, of course, is exactly the same as far as how you're going to mix the bag. Assuming this bag is pre-mixed and pre-flushed, you want to get all the air out of the bag because these are a little more sensitive to air than I've seen these Carlaris pumps. So the benefit to these is that we have a drug library programmed into it, and I really don't think that the people on the TV screen are going to be able to see. But when you turn it on and you click dose, you can actually navigate through the drug library. And for those of you under OMD, you'll have a programming called Code EpiDrip. And I really hope you can see that. And that's what the EpiDrip programming you're going to use. So you get that, attach your tubing just like you would on whichever channel you prefer. Of course, everything's flushed, all the air is out, patient's ready to go. Don't time it because we've already mixed it.
Oh, yeah.
All right. So once you have this all attached, ready to go, you just click OK on the Code EpiDrip, and it's asking us, okay, what's the volume of diluent? Well, we're using a 250 cc bag, so you're going to type 250, enter. Okay, the drug added to the bag in milligrams, so we added 4 milligrams of epinephrine 1 in 10 to the bag, so just type in 4 and click OK. And it'll spit out a concentration it has calculated for us, in which case we're looking at 0.016 milligrams or 16 micrograms a milliliter. Just confirm that. And then the dose, okay, we're either gonna do 50 or 100. So in this case, let's go ahead and do 100 if it was an asystolic arrest. 100, click OK. Volume to be infused. How much volume do you want to infuse? Well, all of it. So just put 250, and that's going to automatically populate that for you. Click OK, and then you're ready to go. Everything is just spitting out numbers for confirmation. So again, the dose, the rate, concentration, confirm all that, and then the time, which means we have about 40 minutes of epinephrine in this bag at that rate. So you click OK, connect to your patient. Once you're ready, it says start infusion. Click OK, and it's started. That's it. Very, very simple. And then if you need to titrate it, patient is now VFib somehow. All you have to do is type 50. Okay, that's it. Oh, you got ROSC and you want to, or you got intra-arrest blood pressure. You want to bring it down 10 or whatever you want to titrate down. Click OK, and you're titrating it. Very, very simple to use. And you can also do the same thing on the other channel as well for any other medications. So that's it.
Cool. Just do right, it's like
Any questions?
right arm.
Okay, guys, a couple quick closing thoughts. First, again, remember you guys are clinicians. You need to understand why you're doing what you're doing, and be able to have a little bit of a discussion with the ER if they have questions. Second, this is a new protocol. There's going to be questions. There's going to be errors. There's going to be hiccups and road bumps. Please sit down with your fellow crew members after every single cardiac arrest and have a very, very frank discussion about what went wrong, what you need to do to fix it. Okay, this is not the time to be making excuses. This is not the time to be, coming up with reasons for whatever. This is the time to identify every single thing that went wrong, whether it be related to the epi drip or to anything else, and give us some feedback about it so that we can figure out what we need to troubleshoot and fix. Okay, just in the 3 times that we've done this at New Braunfels, we've discovered multiple errors, multiple problems, multiple inefficiencies that we've made to make some corrections to. So please, no excuses, sit down and figure out what we need, okay?
And those are kind of keeping my last closing thoughts. So remember, the pull trigger date on this is 15 November. So that should give all departments ample time to play with your pump, practice mixing it up, time yourself, run a mock code and see how long it's taking you to get the epi drip mixed. We all should be familiar with obviously the pumps that we're using and the drugs that we're giving. So all we're just doing is running an infusion where we otherwise give a bolus. So that's why we're not just saying, okay, we have to train up, so start doing it right now. We need to have a couple of weeks to allow everybody to practice. If there's anything that, anything additional that you need on your end, which I don't think there's anything that you need to buy, anything else that you already have. I mean, you already carry your 1 to 10,000 epinephrine. You already carry 2. You may have to get 250 cc bags, but I mean, we all carry 50, 60 cc syringes and needles. So I really don't see a lot of additional things, if anything, that people are going to have to buy. I think we'll be able to make this work with the stuff that we have already. Okay. Lieutenant Maldonado, do you have anything that you want to?
No, you covered everything.
Okay, cool. Well, listen.
I was just going to.
Oh, I'm sorry, Robert. Yes.
So thank you to everybody again. Stephen Wong, Dr. Abraham, Lieutenant Maldonado, everyone here that joined us at VSP. If you have any questions at all, please email them to myself, Dr. Abraham, or Dr. Manifold. Abraham, I went ahead and put those on there. Abraham H at uthcsa.edu, Manifold at utesca.edu, and Moya R at utesca.edu. Any questions, any concerns, we will address those offline and get responses back to you guys. Also, remember that this is, you will receive 1 hour of CE credit, ESHS. The link will be posted and has been posted online. It will be given to those in the class to take the quiz. A certificate will be printed for you at the end to turn into your training officer.
And that post-test is mandatory, by the way. Yes, so there's that. All right, well, if there are no questions, thank you for spending this hour with us. Actually, 7 minutes over, I apologize.